Now, there are other non-traumatic dislocation causes of patellar dislocation as well. Now, commonly, the one way of classifying the patellar dislocation is that it is one form is acute, which is usually most commonly traumatic, rarely atraumatic, but it can be acute. Other is pathological laxity or patholaxity associated causes. For example, patient may have a generalized ligamentous laxity. It's usually bilateral and there may be associated problems as well. And the third one is habitual. Other forms of division of these non-traumatic dislocation can also be classified as, one is called as the habitual dislocation or congenital dislocation. Now, congenital dislocation means which was present at birth. Usually in the children, in the case, for example, a patient having Ehlers-Danlos syndrome, there is actually generalized ligamental laxity even at the birth as well. This may be present with other dislocations like knee dislocation or hyperextension of the knee with congenital dislocation of the patella, or it may be present in isolation only as well. Then includes habitual dislocation. In these children who have actually increased ligamentous laxity, their tendency the patella to dislocate laterally is quite common, and then they have developed a sort of a trach movements in which they can reduce their patella as well. And whenever the knees goes from flexion to extension, their patella dislocates, and from extension to flexion it comes back medially as well. So this form is termed as habitual dislocation. So it's actually really painless, and even the child is not very much aware of it as well. Usually what happens is when the parents see this abnormal kneecaps, they usually come to the doctors for help because they see there's something wrong with the child, but child is usually unaware as it is completely painless problem. Then other problems could be associated with contractures of the quadriceps. This could be associated with any pathology with the problem of quadriceps as well. There may be the lateral structures may be too tight, for example, tightness of vastus lateralis. There could be tightness of iliotibial band as well. And this combined with insufficiency of the medial constraints, this may lead to sort of a contracture of the quadriceps dislocation as well, that whenever the patient contracts his quadriceps, this leads to the dislocation of the patella, and which was actually seen in our patient as well, because the medial constraints were insufficient. The lateral constraints have become over the period tight because of external tibial rotation or torsion, and as a result tightness, they pull the laterally patella more strongly as compared to the medial structures which have to constrain the patella medially. Therefore the patella dislocates with the quadriceps contraction. In this lecture, we have briefly covered recurrent patellar dislocation or instability. Whenever we see a patient, we need to rule out what exactly is the detailed history of the patient. Is it acute or is it chronic? And if it's chronic, is it a one-time episode or is it recurrent? And if it's recurrent, what exactly is cause of the recurrent patellar dislocation? It could be generalized or ligamentous factors. For example, generalized ligamentous laxity or miserable malalignment syndrome, or it may be associated with the osseous factors such as lateral femoral condyle hypoplasia, trochlear dysplasia, patellar hypoplasia, patellar alta, or even the abnormal patellar tilt as well. Or this may be due to the muscular problem. For example, the static constraints may be insufficient, such as medial patellofemoral ligament, or the dynamic constraint, the vastus medialis obliquus muscle may be insufficient as well, and as a result the dislocation may be more laterally. Now generally tendencies of recurrent dislocation is laterally, although it can occur medially and central dislocation as well, but for most of the time it's always lateral. What is important, when we have taken the detailed history and examination and we've done the imaging, we need to make it sure what exactly is causing the dislocation. Is it ligamentous problem, is it bony problem, or it is a combined mechanism? If it's combined, then we need to address both the ligamentous and the bony issue as well. If it's isolated ligamentous issue, we can go for either ligamentous repair in form of a medial patellofemoral ligament or reconstruction. And if it's combined, we can go for the repair reconstruction along with the supra or infrapatellar realignment, or we can go for infrapatellar osteotomy such as Amsel trilard procedure and osteotomy, or even the Fulkerson osteotomy as well. Thank you very much. Keep watching sqadia.com.